to Health Johns. Today, my guest is Dr. Dhaval Desai, Director of Hospital Medicine at Emory St. Joseph's here in Georgia. Dhaval, I'm guessing the term hospitalist will be unfamiliar to many of our viewers. It was new to me when we first met. Why don't you just start us off by describing a hospitalist's role under normal conditions?
Yeah, thanks, Chris, for having me. It's really an honor and pleasure to talk to you. So what a hospitalist does is they are acute care physicians. So if we look at the old days, historically a primary care physician or an internist who works in some type of outpatient environment, sees their patients in the office and also admits them to the hospital and carries them through. In the late 90s, early 2000s, the term hospitalist was coined, and it's really a position designed for a physician that's focused on acute care in the hospital. So our job is to see patients from the time they're admitted, i.e., for example, if you're in the emergency room with a condition and you're too sick to go home, you would get admitted to the hospital and get admitted to the hospitalist service. We see you from the time of admission to discharge. We collaborate with other specialists, other physicians, multidisciplinary teams to ensure a safe discharge when that time is ready. And then we send you home and transition your care to some type of outpatient physician or specialist who will then carry your care afterwards.
Okay, and that all sounds very smooth and seamless. And I'm sure it was up until about March. I'm assuming your average shift now is quite different than it was before the pandemic started. When did you first notice the impact on your hospital?
So, healthcare in general is chaotic to begin with. There's a lot of moving pieces. And, the idea of a hospitalist was really to organize the care, collaborate the care, orchestrate care to become more organized. So time that's spent in the hospital is more efficient. And I think we've done a good job over the years of fine tuning that. It's always a work in progress. But when we, February, March, when COVID really started to make its presence known here in the United States, in Atlanta, specifically in the metro Atlanta region, everything changed dramatically. So, we're used to running operationally a very smooth operation, a very smooth ship, for lack of better words. Everything began to change. It was a little bit eerie at first because as soon as COVID started hitting, we started seeing some cases as things in hospital, outpatient offices started shutting down, businesses started shutting down. We actually initially saw a lower total hospital volume. People were not coming to the hospital. If they were sick, they were avoiding anywhere near where they could potentially get COVID. So that was an eerie kind of calm before the storm. With COVID, it's an entirely different disease process that we were facing. And frankly, we didn't really know what we were getting ourselves into when this first hit. If we look at other pandemics that we've had or other major diseases that we see seasonally, like influenza, we're used to treating that. We feel more comfortable treating that. We have a vaccine against the flu. We know what we can potentially do for the flu. We expect a certain percentage of mortality or death from the flu in a certain season. This was completely different, and it just felt completely unknown what we were doing at the time.
So let's get into that. I mean, I want to hear some of the harsh realities here.
Yeah.
Can you give us a sense of how COVID attacks the body compared to other diseases?
Sure. So, compared to other diseases, everybody likes to compare. I think it's easiest maybe to compare COVID to influenza or the flu. It's spread by respiratory droplets. So when we breathe it in, it'll start infecting our body. COVID is interesting in that we have learned a lot in the last 6 months about what it really does to our body. So we know it affects our lungs, our respiratory pathways, causes significant inflammation. The clinical symptoms, what patients feel, are coughing, shortness of breath, spitting up a lot of mucus or sputum. The severe cases from the lung standpoint are within a few days, some patients feel that they are suffocating. If you've ever been in a pool and you're near drowning, or when you're still learning how to swim and you swallow a bunch of water and you're coughing and you just can't feel like you're catching your breath, that's what we're hearing patients are feeling. And that often happens on day 6 or 7 of their illness. It's not only the lungs that are affected. So COVID can do a lot more to your body. We've learned through the last few months that it has a huge clotting potential. So it causes a vasculitis, inflammation of the blood vessels. Patients can clot very easily. So historically, prime example, you get a blood clot if you're traveling across a transatlantic flight, you've been sitting too long, you get a blood clot in your leg, it spreads to your lungs. So think about a process like that, but that's happening acutely with COVID. So we've seen a lot of clotting that's been catastrophic. Occasionally, you've seen reports that, well, the patient was here in the hospital for COVID and they went home and all of a sudden 3 days later, they died. What really happened? They probably had some type of clotting potential that happened to them after they left the hospital. It can also have a series of cascade of events on the body. We're still learning the central nervous system effects of this. So it can cause delirium, can cause a fancy word we like to use is encephalopathy, which is, confusion, mental status changes. The long-term effects of what happens after COVID, we still don't know. And that's still being studied. The other part of this is it can also affect the heart. So it can cause myocarditis or inflammation of the heart vessel, which is a very scary condition that can cause a lot of potential catastrophic events like fatal arrhythmias or rhythm disturbances also. So these things we're learning over time, Chris, and it's still continuing to be a learning process. We are much better at treating COVID today than we were back in March. If you look at the statistics, just getting into that, purely if we're looking at an Emory healthcare level, there's an 88% survival rate, which is outstanding. So the teams here have done well. And it's not only the hospitalists, there's experts in infectious disease, critical care, pulmonology, everyone putting their heads together for the best care here.
So that's 88% of people who've been admitted to ICUs.
To hospitals in general. Yeah. So hospitals, everybody thinks when you get admitted to the hospital, you're immediately in the ICU. That's not the case. So there's different levels of care in the hospital to acute care, critical care. Critical care is reserved for those who need ventilator support or very high level of oxygen support or cardiac support too. On average, maybe 20 to 25% of your total hospital volume would be a critical care volume. Everything else is general acute care medicine.
I see. Okay. Well, as you know, all along, but especially this past week or two, there's been a lot of confusion and suspicion over what it means to die from COVID. There's all along been rumors that hospitals are cooking the books and have some financial incentive to over-report. And there's also been a lot of ambiguity over how a death certificate works. Could you shed some light on all of those parts of the process?
Sure. And I just want to say it's very maddening when I hear that hospitals are trying to game this and get some type of incentive from this, because we didn't ask for this. Nobody wants to be dealing with this. So we all want COVID over as soon as possible. We do not want to prolong this. So to your point about death certificates and how COVID-related deaths are being reported, death certificates are interesting, and it takes a lot of training to fill out a death certificate in terms of causes of death and what's really going on. So you would think if you were a 50-year-old male that came in and had pneumonia from COVID and ultimately had unfortunately passed away, you could just put cause of death COVID-19, cause of death number 2 pneumonia. It doesn't work like that. So first of all, you can't just put COVID-19 by itself, because the majority of the time you can't just die from COVID-19. You're dying from the respiratory failure from it, from the cardiac compromise from it, or sepsis from it, whatever else is going on in your body. So the way it works on a death certificate is, let's say I died from respiratory failure and pneumonia. My first diagnosis of death would be acute respiratory failure, and I'll put pneumonia. And the third one will be COVID-19. So that's the last thing I can put. After COVID-19, below that, you're not allowed to put anything else legally from the way these death certificates work. So the way these calculations of COVID deaths are being done is, yes, COVID-19 is on the death certificate, but also these 2 other conditions are too. So those are being grouped into comorbidities with COVID-19. But if you think about it, acute respiratory failure and pneumonia, that's not a comorbidity. If I put uncontrolled diabetes, uncontrolled hypertension, or elevated blood pressure, that's my comorbidity. Acute respiratory failure, pneumonia, in my eyes, are acute conditions that are caused by COVID. But those aren't being grouped into, those are being grouped into, these are patients with COVID that died with a comorbidity. Does that make sense, what I'm explaining there?
It does. And if you could relate it to this CDC news release last week, the 94% versus 6%, I think that would be even more helpful.
Right. So 94%, they report 94% of the COVID-related deaths had some type of underlying comorbidity. So I went personally and looked at this, and this is all over. There's articles written about this as well, and I went to go check the sources from the CDC as well. And first and foremost, let me say, I want to have trust in the CDC, and ultimately I still have trust in the CDC. I think it's the way this is being interpreted, and this is the way we're running with these information is what really could be potentially getting us some misinformation or getting us in trouble. But that 94% who had comorbidities, the comorbidities, like I told you, a lot of them are acute comorbidities. So it's not that you had something chronic, you were ill already, then you got COVID and you died. That's not what's happening. You had COVID-19 and your comorbidity is respiratory failure, pneumonia, sepsis, acute renal failure, or kidney failure. That's what's going on.
Okay, that's really helpful. Thank you. So very early on, hospitals had to enforce all these new safety protocols.
Yeah.
Some of them were controversial, one of which was barring visitors from ICUs. Obviously, it made a ton of sense, but emotionally, I think it hit really hard for a lot of families who wanted to be with their loved ones in the hospital. Now, back in April, you posted a story on Twitter about the effects of that. And I'd like to quote what you posted because it really affected me at the time, and I continue to think about it constantly through all this. You wrote, "Today I held an iPad to FaceTime a wife with her actively dying husband from COVID. Seeing her speak to her husband was a depersonalizing experience. It felt like I was watching myself with them in a fictional movie, but it's the new reality." Dhaval, that sounds incredibly hard, and I'm afraid that you must have gone through a lot of experiences like that over the past 6 months, not only one isolated one.
Yeah.
It sounds incredibly hard for them and for you. Why did you describe it as depersonalizing?
So first and foremost, we want patient-centered care. So we want to have patients and their loved ones in a shared decision-making process. And that's what we were doing up until mid-March or so when visitors were or early April when visitors were completely turned off from the hospital. So as I told you earlier when we started talking, is that we've had to constantly change and react ourselves. So when visitors were not allowed in the hospital, and they're still not allowed to this day, it's basically just the patient by themselves. In extreme situations, sometimes visitors can get approved if death is imminent in the next hour or two, but a lot of families do not want to even come to the hospital because of the fear and the risk of COVID. So in my eyes, this is that I know exactly what tweet you're referring to, and I remember what room that patient was in as well. And this actually was, to give you a little bit more background, this is a series of 3 or 4 days that I was caring for this patient when death was imminent, that every day I took the iPad in, and it was Zoom or FaceTime. We had something set up so their wife could talk to them. And it was, the patient could maybe hear what the wife was saying. Occasionally would grimace, would respond a little bit to her voice. But she would be reciting prayers to him, saying things that are more meaningful and personal to them, and just basically saying a goodbye each time she virtually spoke to them. And I'm the mediator holding the iPad in person. And normally these end of life private conversations, we bring families in and I would exit the room so families have that time. I'm sitting there, almost feels like a barrier between them two, just holding the device up and letting his wife have that moment with them. And that story is one that's present, but that story has happened over and over again. And not having visitors in the hospital, Chris, is a huge disservice to the patient because honestly, there's nobody else there to advocate for the patient, especially if the patient cannot advocate for themselves. And we all know that when you're sick, you want somebody advocating for you. We are good in healthcare, we do a good job, but there's nothing like a family member advocating on the sideline saying, "Oh, Chris, he doesn't look right today. Something's different." And I'm saying, "No, he's fine. His vital signs are stable. This is what's to be expected." No, something's different. So those situations are making it much harder on us as healthcare workers to deal and navigate with this pandemic because that layer of communication, that layer of advocacy is gone right now.
So that week in particular, that was end of April. And that week in particular, I think must have been a particularly challenging one for you. Just 3 days after you posted that, Dr. Lorna Breen committed suicide in New York City. She was an emergency room physician at New York Presbyterian. I think for me, as someone who is only tangentially related to healthcare, that was the moment when I realized the scale of this and the toll that this was going to take on the medical profession. Let me quote a couple lines from the New York Times article about her.
Please.
Dr. Brain, 49 years old, did not have a history of mental illness, her father said. But he said that when he last spoke with her, she seemed detached, and he could tell something was wrong. She had described to him an onslaught of patients who were dying before they could even be taken out of ambulances. Do you remember, it's going back a few months now, how you felt when you first heard this story?
Yeah, and it's one I think about all the time, honestly. I'm a big advocate for wellness and physicians taking care of themselves, or any healthcare worker taking care of themselves. But reading her story, and then there was actually a follow-up article, and maybe this is the same one you're quoting from, that kind of goes in a timeline fashion of what happened over her journey with COVID and she was a physician leader in the emergency room. She is used to treating things, fixing things, organizing, a superbly intelligent person who is an amazing leader. But she, time and time again with COVID, realized, I can't fix this. I can't fix the organization behind this. I can't fix the chaos that surrounds this. We did not see the same environment that she witnessed in New York City in that chaos, but we witnessed chaos on a different level. And I'm honestly saying, when I've had the same thoughts, I cannot fix this chaos. I've had to keep telling myself it's going to be chaotic. As a leader of the group, I feel there's 28 physicians that are not looking up to me, but they're looking at me for the next steps. And not having a solid plan time and time again over the last 6 months has been completely a frustrating, very stressful experience. And you really have to keep coaching yourself, saying, this is a chaotic time. This is the way it's going to be. Nobody's expecting you to be perfect. And you keep reading about her story, in terms of her progression. She took time off from work. She had friends come to see her, and she would be calling people on the phone saying, I just can't get my words out. I can't get out of bed. I can't move. She's getting catatonic here. She was essentially getting psychotic in many ways, and she recognized that, but she was sick enough to know that she was smart enough to know something was wrong. She sought the help, and she actually was institutionalized and was discharged. But unfortunately, her suicide followed after her discharge, when she was still spending time with her family out of state. And that's one article. I actually sent that article, Chris, to my whole group, saying that we all need to look at this and recognize that this could be any one of us. And we really have to take care of ourselves. So we've tried to do more wellness sessions, times for us to decompress as a group and talk through things. And that's actually been very therapeutic when we can do that. Not perfect by any means, but therapeutic.
Yeah, I'm glad to hear that. And when it happened, I thought of you not only personally, but I also thought of you in that role of director, and that it must have added a whole other level of another sense of responsibility, like you've just said. Let me quote one more line from the article. This is something her father said after her death. She was truly in the trenches of the front line, her father said. He added, make sure she's praised as a hero, because she was. She's a casualty just as much as anyone else who has died. How do you relate to, we've had conversations about this in the past, battle metaphors, hero, warrior metaphors. How do you relate to all of that language? Do you find it inspiring? Do you find it troubling? How do you feel about all that?
I feel it's completely inspiring. And I really do. And I say that not to self-promote myself, but really recognizing that you don't know how stressful and scary this disease is until you put the PPE, or the personal protective equipment, on and enter these rooms and care for these patients. So myself, the nurses, respiratory therapists, anybody's going into these rooms, you don't know what it's like until you go into these rooms. And that's something we all have to remember, because at the end of the day, when this first started, and we still don't know a lot, but we know things a lot better. We didn't know if the personal protective equipment we were using was sufficient. And there's still back and forth on all of that. And we could go on and on about all the changes that we'd had to react to in terms of the guidelines for PPE, shortages of PPE, how we're going to deal with that, what are our next steps. And it's been a continued change in processes for us for that, as the guidelines keep changing and evolving. And also we have to respond to the supply chain of what we have, and what we can reasonably supply for everybody as well. So I think calling a healthcare worker a hero during this pandemic is very appropriate, very merited, because this is an unknown. This is a completely new disease. There's no vaccine yet for it. It's something that we're all putting ourselves at risk for. And look at there are a lot of healthcare workers out there who have lost their lives to this too. Most are surviving when they get it, but they have been exposed. There are healthcare physicians who are, healthcare providers, nurses, multidisciplinary members who have been severely affected by COVID.
Yeah. And of course, there are lots of other valid parallels as well. Healthcare
Mm-hmm.
workers are experiencing a form of PTSD, almost an aggravated burnout from all this. I know you've been very vocal on this topic yourself for many years. What does burnout do to a healthcare worker?
Yeah, it's a good question. So for burnout, it's not just like you had a bad day, oh my gosh, I'm so burnt out, and you want to go home and just go to bed, that sort of thing. It's a chronic condition that develops over time. Mental fogginess, and the inability to focus, being really short fused, lacking passion and compassion with the patient when you previously would have had that compassion, being dismissive. And there are a lot of times very subtle things that come up that are slowly accumulating over time, and the burnout peaks, and then an intervention has to be made at that point. And I think all of us in healthcare are feeling that and have felt that at some point during this. I felt that. I took a week and a half off completely, and I feel much better at this point today talking to you. But this PTSD from COVID, I think we're still going to be seeing ongoing issues related to burnout. And we need to look out for the mental health and the wellness of our healthcare workers, because we're at a point, we're in crisis mode where the adrenaline is now fading, and now the reality of the chronicity of this is setting in. And are we going to still have that strength and willpower to fight just as aggressively if we hit another surge, which we're all fearful of?
Yeah, remember we were on the phone about maybe back in April, and you told me then, this seems really prophetic now, but you told me you were really worried this trauma wouldn't hit healthcare workers for about 6 months. You were really scared about what September, October would look like. Well, we're here. How do you think healthcare workers are coping overall at this stage?
They're tired. They're tired. They're fatigued and tired. That's the honest truth right now. I don't think we're at risk that we're going to have a mass exodus from the profession right now, but I would still say that the fatigue, the exhaustion is there, burnout is there in a lot of people that weren't experiencing it previously. I feel, and this is my personal opinion, but in the next 6 to 12 months, there may be shifts in the way where the people are working in healthcare. People may want to get out of the hospital environment and go to a more safe environment where they can still practice some type of healthcare, but not have the continuous risk of being exposed to COVID-19 and dealing with the pandemic. And those are all realities. There's always going to be people here that are going to, be in the hospital on the front lines taking care, but if you look at, it'll be interesting for me and probably from a lot of people in healthcare workforce to look at the shifts that happen over the next 6 to 12 months, because I think some of this is going to be inevitable.
Okay. So, of course, the thing with trauma, unfortunately, is that it never ends up just affecting a single person in isolation. There's always that ripple effect, what we call secondary trauma, which can impact entire families. I assume the same applies in a certain degree to burnout. Now, Dhaval, you're married. You have 2 daughters now?
I have a 4.5-year-old daughter and a 6-month-old son.
6 months. Okay. So that means...
He was born 2 weeks before the pandemic started.
He was born before the pandemic.
Yeah.
So what has all this been like for them? What has this been like for you and your wife with a newborn throughout this entire pandemic?
Scary, very scary. So my wife's a physician too, so she is actually very level-headed and has a good understanding of things. For better or worse, we know enough, and that can sometimes get us into trouble too, because the nuances can really come up when, that hypervigilance can continue to be an issue for us. So, we're the first and foremost, I have to protect my family. I was not that person that would not go home after leaving the hospital. Or stay somewhere else or get a hotel room, that sort of thing. I can't be away from a 4-year-old and a newborn. There's just no way to do that. And I would not want to do that. So unless I was exposed or there was a significant risk. So I can be open and share what we do, what the routine is for me when I leave the hospital. So wear scrubs. This is what most people are doing too, by the way. So wear scrubs to the hospital before leaving the hospital, change out of scrubs into another pair of clothes. Those pair of scrubs you're wearing go in a bag, so it's not touching anything. That bag goes into your work bag. Walking out in street clothes, so you don't want to get the dirty scrubs, so to speak, on your car. Go home, and in the garage or wherever you go in, completely disrobe down to your undergarments, keep your shoes that you're wearing in the hospital outside, don't bring them in, and go in, tell my daughter, close your eyes, and I run in the shower, and the next thing, shower, completely clean yourself off before you start touching anybody and doing anything. And most people are following that sort of routine right now, and it's been quite changing for all of us to do that. At first throughout this, I didn't want to kiss my children because what am I bringing home to them? We've been a little bit more liberal with that, obviously, as things move on, but it's definitely a challenge. Any symptom that we have, we're always hypervigilant that is this COVID? Is this what I'm brought into the hospital or brought into my home rather? My children, both of them had this summertime 24-hour virus and about 2 months ago. And that was the most scary 24 hours, not because they had a virus or they were sick, but because first thing we thought was this was COVID. And then you feel guilty that I did this and I brought this home to my family. And if I ever did, I'd feel immensely guilty. And I'm sure there'd be secondary effects on the family and the marriage on that. So indirectly. So those are all things we're all dealing with. And that's the truth.
Oh, I'm so sorry to hear that. I mean, I come home from work, all I have to do is sit my backpack on the ground. I mean, compared to what you go through, it's just unbelievable. I remember you mentioning too, back in April, that you and your daughter were practicing what you called air hugs.
Yeah, she still does air hugs. Yeah, that's what we do, air hugs. Put your arms out, keep some distance.
From 6
feet.
Yeah.
So even, when she sees her grandparents who live around about 10 minutes from us, we do air hugs. They're not, we're not isolating from them, but we're being really careful with that. So it's a new normal for our children. I don't think my 6-month-old knows anything outside of people wearing masks. So he doesn't go out very often. So it's interesting. There's no evidence to what I'm saying, but he has a lot more stranger anxiety than my other older one did at this age. So he hasn't been out. He's been cooped up home. He doesn't know what people exist, restaurants, stores, that sort of thing. So remotely, when we even go in the car and he sees other people, he gets really anxious and scared. And some of that's age-appropriate developmental behavior, but you have to wonder how much of that is because we was not exposed or we didn't because of the pandemic.
And the 4-year-old?
She's hanging online. Say that again.
She's starting first grade online this fall or what?
No, so she's pre-K still. So she has a preschool that she was going to, and we actually made a decision to pull her out of it because there was 2 or 3 children that did have COVID there. And this is it's an individual family decision. So every family has to make their own decision what's right for their children. For us, it made the most sense that we didn't want her exposed for any child-to-child transmission and bring something home to our infant at the time who does not have a strongest immune system yet. So she's doing some home local potting with another classmate, and we're keeping it really small scale and protected right now. We'll have to make a decision next year when she's in kindergarten and full time, but hopefully we'll be in a better spot by then.
Hopefully.
Yeah.
All right, so just to wrap things up, Dhaval, I would like to just give you the floor to send any message that you would like to people who don't work on the front lines. What would you most like people who aren't healthcare workers to hear right now in terms of what we need to all do together in the next 6 months?
Yeah, we all need to follow guidelines. So COVID-19 is real. It's here. It's not going anywhere. We all need to be vigilant. We're going to have moments of ups and downs with the numbers until we have vaccine and everybody's vaccinated and we're getting better on our incidence of the new cases. But wear a mask, socially distance yourself, wash your hands. And if we do that, we're really protecting the healthcare workers at the end of the day, because we're not going to be in a position where we're getting ourselves sick enough to be admitted to the hospital. So I'm a big advocate that if we can do all of these measures, not only are you going to help yourself and protect yourself, you're going to protect the cascade of other people by not succumbing to the catastrophic effects of these disease process. So those are my biggest things, simple things that we can all do. And, I want to reinforce that I do think healthcare workers are heroes right now. And that's not to put us on a pedestal saying we're superior to anybody, but honestly, what the challenges that they have had to face in and out of this situation has been unreal and unprecedented. So that has to be said.
Yeah. Well, Dhaval, I'm grateful to count you as a friend. It's been an honor to have you on the show. I just hope that everyone in your position has the chance to just breathe and start to process all of this stuff very, very soon. Thank you for coming on the show.
Thanks for having me, Chris.